At the outset, at the outset, I thank Sanjit sir and Vek sir for giving me this opportunity. Today I am going to discuss neck pain and back pain. So here is the statistics which shows the prevalence of back pain is so large. 84% of adult male have an episode of low back pain in their lifetimes, of which 85% will be caused by a non-specific low backache, meaning there is no specific etiology. Most of the individuals will have a self-limiting episode. The prevalence of low back pain is between 22 to 48 and neck pain is 10 to 20. So the risk factors for back pain are obesity, increasing age, heavy manual work, smoking, and deconditioning. So briefly on the anatomy, spine. So the central, the interdisc, the disc is formed by two main structures. The central gel-like material, which is called as nucleus pulposus, surrounded by annulus fibrosus. As the patient, as somebody gets aged, the water content in the nucleus pulposus gets reduced and becomes thin, so that it becomes weak and tends to rupture. The posterior longitudinal ligament, which gets thin as it comes down the lumbosacral segment, gives way easily. That's why the disc prolapse is more common in the lumbosacral region. So what are the differentials for low backache? It can be a mechanical back pain. It's a non-mechanical spine disease or a visceral disease. In mechanical back pain, it's again can be musculoskeletal pain or a neurogenic pain. It can be a simple lumbar strain, or it can be a degenerative disease like disc, facet joint arthritis, spondylolisthesis, herniated disc, spinal canal stenosis, and congenital diseases. Non-mechanical spine diseases can range from neoplasia, infection, inflammatory arthritis, and Paget's disease. Visceral diseases like pelvic organ disease like prostatitis, endometritis can present as low back pain. Similarly, renal diseases like nephrolithiasis or pyelonephritis can present as flank pain or back pain. Aortic aneurysm can present as back pain. So when you evaluate a patient clinically with back pain, you have to focus on three things. Whether it's back pain or neck pain, we have to focus on three things. First one is the description of the pain. Second, to determine if there is a neurological cause for pain. And third, identification of the red flags, which means some serious spinal pathology which has to be intervened urgently. So coming to the pain description, the duration, based on duration, can be acute, subacute, or chronic. The duration gives us a framework for the evaluation and treatment of back pain. The most musculoskeletal low back pain will resolve by 2 to 4 weeks, and acute radicular pain will resolve by 6 to 8 weeks. So no aggressive evaluation is needed if the pain is acute without any red flags, or if the pain is chronic without any recent worsening. Location, usually musculoskeletal pain will be poorly localized, mostly at the center of the low back. The radicular pain will be radiating along the dermatomes, and any pain around the neck, periscapular region, pectoral region can be due to the rupture of the disc, and the pain radiating to the limbs. Upper limb will be due to a root compression caused by the disc. Severity has to be assessed, which may depend on the psychosocial factors and cultural factors. So most important thing, what are the triggering and relieving factors? Neck pain, which aggravates by bending towards the same side of the pain. For example, somebody has a pain on the right side, and the pain aggravates on turning towards the right side. It means it's a disc causing the compression, and the pain which aggravates on turning towards the opposite side means a myofascial pain. A pain that is worse on sitting and improving with standing or lying posture means a disc disease, because the intra-disc pressure, which will be lowest on lying down, on getting up the intra-disc pressure gets increased. Similarly, on sitting down, the intra-disc pressure further increases. So any disc disease will cause maximum pain on sitting than while standing and lying down. Similarly, the pain which is worse on standing and relieved by sitting will be due to musculoskeletal causes like facet joint disease, osteoarthritis. The pain which is worse on standing and walking, which means a neurogenic claudication caused by spinal stenosis. A pain that is worse on transition between sitting and standing position can be due to sacroiliac joint disease, and the pain that persists on all positions is maybe due to malignancy, infection, or ankylosing spondylosis. So look for neurological involvement in the form of radicular pain, weakness in both or one or both limbs, history of any neurogenic claudication. So claudication, we have to differentiate between a vascular claudication and neurogenic claudication. In neurogenic claudication, apart from pain, patient tends to have paresthesias, weakness, which will be aggravating while walking, and by leaning forward or taking rest, the pain will come down. So look always for red flags. The serious spinal pathology, which is very rare in primary care setting, has to be identified by the red flags for these three disorders, namely cauda equina compression, malignancy, and vertebral infection. These three adverse conditions should be identified by the red flags. So the red flags for cauda equina will be bowel bladder disturbance, saddle anesthesia, bilateral asymmetric deficits. Red flags for severe neurological involvement will be rapidly progressive deficits, multi-level or bilateral involvement, and prominent weakness at the onset, like foot drop or hip flexion weakness. Red flags for cancer will be prior history of cancer, unexplained weight loss, pain on supine position, age more than 50 years. Red flags for spinal fracture will be chronic steroid intake, age more than 70 years, and trauma. And the red flags for spinal infection can be fever, IV drug abuse, and recent infections. So in the initial setup, we have to look for these red flag signs. On physical examination, look for sensory loss or hyperesthesia along the specific dermatomes. Myotomal pattern of weakness has to be assessed. Despite pain, will have limitations to assess the power of the patient. Yes, yet the individual muscles within L2 to S1 dermatome, especially L5 to S1 dermatome, has to be examined because 95% of this disease involves L5 to S1. Check the power for ankle dorsiflexion, great toe extension, knee flexion, hip flexion, and knee extension. These are the 4 important muscles that has to be assessed. So this is the picture, shows the 3 key segments L4, L5, S1. In L4, the pain will be from the lateral to the anterior aspect. L5, the pain will be in the lateral aspect, and S1, the pain will be in the posterior aspect of the leg. Similarly, check for if there is a quadriceps weakness, L4 root, dorsiflexion, great toe and foot, L5 root, and plantar flexion of the great toe involves the S1 root. Similarly, absent knee jerk and ankle jerk are important for L4 and S1 root involvement. So deep tendon reflexes are unaffected by the patient's effort as well as by pain. So asymmetric absence of knee jerk and ankle jerk are very significant neurological findings. Patient reported with bowel and bladder disturbance, assess rectal tone, saddle anesthesia for cauda equina dysfunction. Assessing the gait, spinal canal stenosis, patient will be comfortable on flexing forward because at flexing forward, the spinal canal has a maximum diameter. So they tend to flex forward. Trendelenburg gait shows there is a hip abduction weakness. Stressed gait testing is by making the patient to walk on toes or heel, which is a very sensitive test than direct manual testing of power. Inability to walk on toes points towards gastrocnemius weakness, which is S1, whereas difficulty on walking heel indicate foot drop, L5 root weakness. So these are the various maneuvers that can be tested. SLR is straight leg raising test, in which the examiner raises the lower limb, and when the patient symptoms of reproduce between 30 to 70 degree, it means L5S1 root involvement is there. So any pain less than 30 or more than 70 is considered as normal response. Crossed leg raise is one in which the opposite limb is raised. Patient gets the similar symptoms. It's more specific than the straight leg raising test. Bragard sign, this is a variation of straight leg raising test in which the examiner raises the lower limb and flexes the foot at the ankle, which increases the nerve tension and produces the pain symptoms. Femoral stretch test is called as Faber's test, in which the patient in prone position, the lower limb is elevated and knee is flexed. This shows if patient gets pain, the lesion is in the L4, L5 root. Similarly, Patrick test is otherwise called as Faber's test, flexion, abduction, external rotation test, in which the foot is placed over the opposite knee joint and the knee is flexed towards the examination couch. This means there is a pathology in the sacroiliac joint. Coming to the imaging modalities, in the absence of red flags, imaging is not indicated if low back pain is less than 6 weeks duration. Unless there is evidence of progressive severe neurological deficit, fever, acute trauma, sudden back pain with spinal tenderness, or strong clinical suspicion of underlying systemic disease, we don't do an imaging in the first 6 weeks. Coming, what are the available investigations? Radiography, which is available readily. It is sensitive for bony spine and its alignment. MR is a more investigation of choice when we suspect a neurological pain because it optimizes the spinal cord, disc and nerve roots. Malignancy and infection also can be diagnosed with the help of MRI. Gadolinium is indicated if we suspect an intradural or leptomeningeal disease. But certain MRI findings have uncertain significance, like annular tear, small modic changes, and disc degeneration is more commonly seen in younger people, especially asymptomatic younger individuals. So MRI can be misleading, and early MRI may lead to increased cost as well as surgeries. CT may be more sensitive to detect bony abnormalities. Coming to the treatment aspect, the main goal for the treatment of acute back pain or neck pain will be pain control and preservation of function. Conservative management of most cases of acute back pain is supported by a favorable prognosis. So the conservative managements include NSAIDs, muscle relaxants, applied heat and self-care, which includes return to usual activity at the earliest. If the pain is severe, a short period of rest for 1 to 2 hours can be allowed. Avoid lifting heavy objects and lumbar pillow support for travel. In case of a radiculopathy, additional use of drugs like gabapentin or pregabalin can be advised. A 50-day course of oral prednisolone results in improved function at 3 to 52 weeks, but no significant change in pain or long-term surgery. Epidural steroids provide short-term benefit, but it lacks clear long-term benefit, and still it's a controversial. Patients with significant motor weakness should undergo early imaging, and surgical intervention may be needed to prevent permanent deficits. Spinal canal stenosis doesn't respond much to medical management. Surgical evaluation is often warranted in patients with progressive and disabling symptoms. Surgery is warranted in case of a cauda equina compression, radiculopathy with rapidly progressive severe neurological deficits, spinal stenosis, and milder deficits with structural lesion on MRI and active denervation on EMG. In case of a chronic back pain, we have to attend to the psychosocial factors, analgesics, NSAIDs, gabapentin, topiramate, and antidepressants like duloxetine may be used. Complementary and alternative medicine practices may be beneficial. Short-term pain reduction also may be seen with the herbal preparations, and risk of opioids in treating non-cancerous low back pain outweighs the benefit. So we are not supposed to use opioids for chronic low back pain. So this will be the flow chart. So the acute back pain, whether it is musculoskeletal or radicular, look for red flags. If there is a red flag, go for imaging. If there is no red flags, go for conservative management for 4 weeks. If the symptoms are improved, fine. If the symptoms are not improved, again look for red flags. If present, go for imaging. If still there is no red flags, you can continue conservative therapy for 2 more weeks. If there is no improvement, you have to go for imaging and investigate further. So here is a patient, 57-year-old woman, previously healthy with 4 months history of intermittent low back pain, worse over the last 3 weeks. Patient was carrying a heavy object. She developed severe right-sided back pain that self-resolved in 2 weeks. This pain again occurred after 2 months, which also improved on its own. Just 2 weeks before this presentation, patient developed severe pain accompanied by burning paresthesia down the right buttock and posterior thigh, which progressed with difficulty in walking. The pain was worse, not relieved by NSAIDs. The patient was not able to sleep. She denied any history of trauma. Examination showed right gastrocnemius weakness and reduced right ankle jerk. So MRI was done, which shows a compression fracture at T12 and L5 vertebral bodies with the diffuse abnormal signal throughout the spine and bilateral sacrum. So in this case, there were 2 episodes without any red flags, but third episode, there was a red flag in the form of radiating pain and weakness. So the patient was evaluated. She was diagnosed as multiple myeloma and treated with chemo. So any acute low back pain or neck pain, look for whether it is, look for any neurological cause, especially look for red flag signs, and in acute management, go for a conservative management, and if there is a neurological red flag, the treatment has to be tailored accordingly. Thank you.